Here is the back page or the second page of a medical symptoms questionnaire, and we notice that 19 symptoms are under digestion. That's like a third of all of her symptoms, or 19 points anyway. That's a third of all of her points on this total score of 64. So probably intervening in the gut would be kind of a good idea. So we're going to initiate assessment and care. How are we going to do that? Well, we're going to use tools. So we have these assessment tools, the timeline, the nutritional assessments, the ABCD of nutritional health, and so on. We have intake questionnaires. And then, so we gather all this information, and then we organize the information. We use the timeline as a tool to sort of uncover some of this complexity. And then we do interventions. And, so there's some first-line interventions. So we've got sort of fundamental diets, a core food plan, vegan or vegetarian food plan. We've got sort of first-step interventions, like a cardiometabolic diet, elimination diet, and then some more advanced interventions, like a detox program, some GI-specific programs, Mito food plan, and this thing called a Renew diet. So there's going to be an entire lecture by an MD-RD, I think tomorrow or the next day. So they'll go very deep into the elimination diet. So how about some practical applications of this? What does this patient need to have removed? And why would we care? Why would we want to remove certain foods? Well, an elimination diet really addresses every area of the matrix. So it supports healthy microbiome. It's dairy and gluten-free, which are two common allergens and sensitizing things. It's high in phytonutrients. It reduces toxic burden. There's no calorie restriction, so you can eat all you want. It promotes body awareness to food. It identifies food triggers. It reduces inflammation. The problem is people are used to, pasta and vegetables and a little piece of meat, or maybe even a big piece of meat. And so they take away the pasta, and now they got this piece of meat and this little thing of vegetables that are, or, if you go and they ask you, do you want French fries or fruit? Right? They give you 4.5 pounds of French fries and yesterday's melon that's dehydrated. It happens every time. So what do you have to do if you're going to go on this diet? You have to increase the portions of the things you are allowed to have. How is an elimination diet related to the 5R? What part of the functional medicine matrix will the elimination diet touch? The answer is all of them. So let's look at some laboratories. So we did some primary laboratories on Joan. Her CBC was normal. Her ferritin was okay. Her thyroid was okay. Her vitamin D was sufficient. Serologies. She has IgA immunoglobulins are normal, so she's sufficient immunologically. TTGA is negative. Deaminated gliadin is negative. Endomycelial antibody is negative. A SIBO breath test is within normal limits. So what do you think? Have we ruled out celiac disease and gluten sensitivity? What do you think? No. So here we go. We did a stool test, and parasitology shows growth of Blastocystis. 3 out of 3 samples show growth of Blastocystis. Now, additionally, a culture shows these expected bacteria and these commensal imbalanced bacteria. So there's some evidence of dysbiosis, both parasitologically and prokaryotically. And then there's also some yeast. It's only 1+, but you heard Tom O'Brien say, we're testing the 1 inch of stool. If I see this stuff, I'm probably going to think hard about it. I may not treat it, but if the signs and symptoms, and that's kind of what happens to some of these bacteria. If we think that the cause is dysbiosis, and there's a bug there that doesn't look or smell or act right, then we kill it, or try to kill it anyway, and it's not always easy to kill these things. So what do we know about blastocystis? What do we know about dysbiosis? Well, we know that blastocystis is very common. And then, is blastocystis a pathogen? Well, it turns out there's probably some differential pathogenicity. So of these 515 people who seem to have blastocystis, 239 of them, about 46%, were found to be symptomatic. 43 of those 239 people, I don't know why such a small number, but 43 of them were treated with metronidazole and their symptoms resolved, and their follow-up stool was negative. So blastocystis appears to have some kind of differential pathogenicity. There are 17 subtypes, and it may have something to do with subtypes, but subtype testing isn't that common, really. And it may also just have to do with the confluence of things. Maybe there's other things that are causing some intestinal permeability, and then the blasto becomes opportunistic. So what about symptoms? Well, patients with pathogenic effect from blasto have IBS-like symptoms. They can have cutaneous symptoms. They can have mast cell degranulation with increased histamine. All the rage these days is mast cell illness of some kind, right? Well, I think we have to ask the question, why are their mast cells so upset, right? It's not just, oh, you have mast cell illness. Maybe your mast cells are upset for some reason, and maybe it's blasto, maybe it's something else. And then short-term exacerbations with die-off are not uncommon. So what is this? This is this Herxheimer reaction. So does blastocystis increase intestinal permeability? 39 patients with protozoal infection were compared to 10 healthy controls. The increase in intestinal permeability in patients with blastocystis hominis suggests that it can be a pathogenic protozoa. Can other protozoal infections increase intestinal permeability? Well, it turns out Giardia can. So, does dysbiosis increase intestinal permeability? Yes. What a surprise that is, huh? And, one kind of increase of dysbiosis is this thing called small intestine bacterial overgrowth, or SIBO. And so, the prevalence of SIBO, look at this. Celiac disease. Lots of people with celiac disease have SIBO. Chronic fatigue. Most people with chronic fatigue. Most people with Crohn's. At least a significant fraction with diabetes. Most with fibromyalgia. Hypothyroidism, half of the people with hypothyroidism. Immunodeficiency syndromes, half of the people have SIBO. Dysmotility issues, most people. Obesity, most people. Parkinson's, half of them. Rosacea, half of them. And ulcerative colitis, most of them. So, this idea of dysbiosis, it certainly is a smoking gun. It might not be a bullet hole for sure, but it's a smoking gun, right? And often, clinically, we find if we treat this, other things mysteriously get better. Is inflammation linked to increased intestinal permeability? And the answer to that question is yes, through these sorts of mechanisms. You have environmental factors, foods, gluten, casein, toxins, stressors, dysbiotic organisms, all contribute to increased intestinal permeability, and that results in a leak of lipopolysaccharides and other immune activating and inflammatory molecules across the mucous membrane, which upregulates inflammatory cascades. And then that causes increased leakiness, which of course makes this feed-forward loop. It makes the problem escalatingly large rather than diminishingly small. Is inflammation linked to depression? Lots of studies tell us that inflammation is linked to depression. So, yes, it is. And finally, is intestinal permeability linked to depression and potentially some of Joan's health illnesses? Intestinal mucosal dysfunction characterized by increased lipopolysaccharide translocation may induce specific sickness behaviors, including symptoms of depression. So yes. So we're back to this. We're back to, I learned where the antenna is, now I can point it in the right direction. We're back to this. We're back to what are we trying to do in functional medicine? We're trying to manage this cascade, among other things. So what are some pharmaceutical treatments for parasites? And I'll tell you that I just used the Sanford guide Look it up. I don't memorize this stuff. I wouldn't ask you to memorize this stuff because it changes every 14 seconds. Every time somebody spends another $300 million on a study, we get a whole new thing to do. So here are some suggestions. They'll be in the notes. And then some botanicals. Black walnut, wormwood, which is, by the way, Artemisia is absinthe, the active ingredient in absinthe, that green liqueur stuff, or maybe it's not a liqueur because it's bitter, and then bitter wood, garlic, golden seal, and then oil of oregano is a great antimicrobial, olive leaf extract, citrus seed extract. So this is an interesting study, I think. Clinical effects of Saccharomyces boulardii, which is a probiotic yeast. It's not technically a probiotic, but we call it that. Or metronidazole in symptomatic children with Blastocystis hominis, and the cure rates were almost equivalent. So what it looks like here is that if you have somebody who has Blastocystis, you can treat it with Saccharomyces and expect a similar cure rate as metronidazole. So treating pathogenic organisms versus treating dysbiosis. And there's a continuum here. Dysbiosis doesn't have to be the presence of a pathogen. It doesn't even have to be the presence of an abnormal bacteria. It can just be a disorder of the bacteria. It can be an imbalance of the bacteria. It can be just like the case I was telling about, maybe just no lactobacillus or very low lactobacillus. So how do you treat that? Well, as I said before, it's, what is it? Field of dreams. If you build it, they will come. And we want to change the environment. We want to build a better environment in the gut, and then the good bacteria will come. So we want to change the diet. We want to, as Tom O'Brien was talking about, more root vegetables, more prebiotic vegetables. And if necessary, maybe some antimicrobials. I don't typically use antimicrobial botanicals. I use some of them, but mostly I use more smart bombs. I like to use colostrum or serum-derived immune globulins or whey immune globulins because they're targeted. Cows have similar probiotics that we have, and their immune system doesn't typically try to kill off the commensal healthy bacteria, but they have a vast array of antibodies against dysbiotic organisms. So by using these more targeted therapies, we're not disrupting the probiotic species as much, we're inhibiting the dysbiotic species and allowing the probiotics to then flourish and push out the dysbiotic species. Antimicrobial pharmaceuticals and or botanical treatments should be reserved for more significant cases or for actual pathogenic infections. So we have this continuum of normal to not normal. And we go from, just maybe adding a few prebiotics to a wholesale change of diet and lifestyle to adding some botanicals to adding some antimicrobials. So, as you know, generally speaking, antimicrobials are 7 to 10 days, whereas botanicals are going to be much longer, 4 to 12 weeks. Rifaximin has become sort of the standard of care for SIBO. It's always interesting to me when the standard of care is not covered by any insurance. Go ahead and try to get some rifaximin for somebody. They'll give you, it's really bizarre. They'll give you, like maybe one prescription of 500 milligrams twice a day for 5 days, once every 6 months. And the problem with this, if rifaximin is not 5R in a box. So if you give somebody rifaximin, certainly you kill a whole bunch of bugs and they feel better for a while, but especially if you don't do that rebalance step, let alone the other 5Rs, it just comes back. Within days of stopping the rifaximin, the symptoms are right back. So it's really not the treatment of choice, despite the fact that it's considered the treatment of choice. So here are some botanical antimicrobials. There's just a list for your notes. And then what else have we learned about Joan's GI function from her stool analysis? So what do we need to replace? Well, here we are with this pancreatic elastase 1 business. Well, what on earth does this mean? Does she have pancreatic failure? You know, certainly it's not endocrine pancreatic failure. She doesn't have diabetes, but is it exocrine pancreatic failure? No. She has a feedback loop problem, which I'll show you in a minute. But first I want to talk about what is this? It's exclusively human. So when you're giving somebody bovine digestive enzymes or whatever, plant digestive enzymes, there's no elastase 1 in it. So, you know, you can do a stool analysis and not worry about contamination. What's happening here is there is a signaling pathway between the duodenum and the proximal small intestine and the pancreas. It has to do with cholecystokinin. And when you have injury to the brush border, you don't get a robust release of cholecystokinin, which means you don't get stimulation of the pancreas to release elastase. So when you see elastase being low, it is evidence of brush border injury, and it is evidence of loss of cholecystokinin feedback. So that's really the clinical pearl there. That's evidence of leaky gut. It's evidence of brush border injury. We need to masticate our food. Now, there's so much that can go wrong, right? Low hypochlorhydria or low acid, not low hypochlorhydria, it's hypochlorhydria. We talked about pancreatic insufficiency and why that happens, brush border injury, bile insufficiency. Your body only makes a certain amount of bile per day. It's actually only a few grams. Anything that, as one of my professors chose to say, anything that causes intestinal hurry might cause bile insufficiency, because you're going to be getting rid of more of it than you can actually produce in a day. So if somebody has some kind of chronic diarrhea as a component of their gut issues, probably you need to be thinking about some ox bile or some kind of bile supplementation. How can you tell the difference between hypochlorhydria and these pancreatic enzymes? And there's lots of symptoms here, as you can see, bloating and belching immediately following a meal versus indigestion and fullness 2 to 4 hours after a meal. I think that's really the divider here. I mean, you can look at all these other symptoms, but it's a timing issue. If you've got low acid, that happens immediately. If you have pancreatic insufficiency, that has to travel through the pylorus and into the duodenum before you get a problem. And how do you assess it? Well, clinical signs and symptoms, it's really the timing. And then you can do this thing called a betaine hydrochloride challenge test. For pancreatic insufficiency, you can measure an elastase. So digestive support, maldigestion equals incomplete food processing. Do they have insufficient hydrochloric acid? Do they have insufficient intestinal brush border enzymes? Those are the disaccharidases. This is what we encountered on the pediatric ward. You know, the kid's got diarrhea and now he's got lactose intolerance until his gut heals because he's lost his brush border where the lactase lives. So, you know, kid with chronic, or not chronic, with acute viral gastroenteritis, you kind of want to take him off of lactose for a while to let his gut heal, right? And then do we have, is that brush border causing cholecystokinin insufficiency and thus causing a pancreatic release problem? And then do we have insufficient bile? And so betaine, how do you do that? Well, there's actually a whole handout on how to do it, but you give some tablets for protein digestion. Here's some Japanese plum, enzymes that have a broad pH range. Those are generally called plant-based enzymes, which are actually fungal-based enzymes, but that freaks everybody out, so they call them plant-based enzymes. Swedish bitters, vinegar, decreased stress, vagal tone. We talked about being in fight or flight. And here is a cover sheet from the toolkit testing low stomach acid. So there's a whole handout on how to do that. How do we treat pancreatic insufficiency? Well, with lipases, mixture of lipases, proteases, and amylases, porcine or bovine-derived products, plant-derived products, and we mix them with the meal. And how do we think about other digestive factors? Cholagogues and choleretics, these are agents that promote the flow and production of bile. So if you're not too into ox bile, you could try dandelion root or taurine. I want you to think about remove and replace from the point of view of Joan's specific case. We're going to go through it after you talk about it, but I want you to think about it. Think about Dr. O'Brien's session and the remove and replace steps. My thought was we would do an illegal antigenic diet, an anti-parasitic protocol, of both a prescriptive thing and some kind of botanical thing, and with the more recent data, I'd probably throw in some some Saccharomyces just for good measure. Because she had that low pancreatic enzyme, I'm going to give her some pancreatic enzymes, not forever, but until we change the milieu so that she has a better cholecystokinin feedback. And then, you know, does this patient need to have gut flora reinoculation? So we're going to determine the need to support the intestinal milieu with prebiotics, probiotics. And I want to think for a minute about microclimates. We have a microclimate vertically from the mouth all the way down to the back passage, as my British pathology professor liked to call it. And we also have microclimates within a single ring of the lumen. We've got this 30-micron biofilm that's intimately associated with the mucosa of the gut, and then progressively into the center of the stool, and they are different places. Just like in the Napa Valley, we've got all these wonderful places to grow grapes and the kinds of influences. So, you know, we keep talking about which bug is there. But as we'll see coming up, that's just like the kindergarten version. What about, you know, what's the metabolic activity there? What's the influence of the microclimate? And is it really the bug that's important, or the bacteria, the bacterial effluent that's important? So it's much more complicated than just which bug.